Thank you, all of the audience. And I would like to start one of the highlight satellite symposium. This symposium was sponsored by Boston Scientific, and the title is Transforming PCI with Synergy, New Version of Drug Eluting Stent MEGATRON, and the purpose built for large proximal vessel. So I'm gonna introduce and our co-moderator, the world-renowned interventional cardiologist, Dr. Huai Chim Tan from Singapore. We also invited and the expert panelist, Jae-Sik Chang, the Haeundae Baek University in Korea, and the Yu Jung-gi, and the Ujeongbu Ulji University in Korea, Lee-Sik Kim, and the Jeonbuk University in Korea, and the Professor Young-Hyo Lim, and the Hanyang University in Korea. First lecture, I would like to ask Dr. Tan, and the title is Synergy Megatron, Advancing Your Large Proximal Vessel Strategy for Improved Outcome. Dr. Tan?
Thank you very much, Dr. Park, for the very kind introduction, and really great to be among the esteemed colleagues from Korea. So my talk is to introduce the background to this Synergy Megatron stent. As we all know, Synergy Megatron stent is the latest addition to the family of Synergy Platinum Chromium Everolimus Eluting stent that we come to know about since 2012 when it was first introduced in Singapore. So now if you look at the the Megatron stent versus the conventional Synergy stent, there are similarities. They are both platinum chromium steel as the metallic platform. It is still everolimus coated, and it's got a 4 micron abluminal drug coating, which is facing the wall. But this is where the similarities lies. The Megatron is different from the current Synergy stent in that it is most importantly thicker in terms of its strut thickness and overall thickness compared to the Synergy stent. So if you look at the current Megatron stent, it has 4 connectors in the first 2 segments of the stent versus 5 connectors in the largest version of the Synergy stent. But the other differences will be that it's got 3 connectors in the rest of the body of the stent, whereas the usual Synergy stent has got only 2 connectors throughout the body. What is also important here is that we have 12 peaks in the Synergy Megatron stent compared to only 10 peaks in the Synergy stents. So what does this difference in peak mean to you? When you actually have more peak, and so for example, this 12 peak design of the Megatron stent compared to a prototype DES of just 9 peak, you find that when you have a fewer peaks, there's a higher likelihood of a tissue prolapse and going through that the stent struts. While you have more peaks, then the tissue prolapse will be less. And so in so doing, by minimizing the tissue prolapse with this Megatron stent, you can maximize your luminal gain following a stent implantation. On top of that, we know that Synergy stent or platinum chromium has got the highest radial strength compared to the other metallic platforms such as stainless steel or the cobalt chromium. So, you know, platinum chromium stent has got 73% more radial strength than cobalt alloy stent, and Megatron stent is way high up here in terms of its radial strength. In comparisons to Zion stent or Resolute stent, if you measure axial strength, which is the force to cause 1 millimeter of deformations on the proximal 3 millimeter of a stent, you find that it takes 44% and 43% more force to compress Megatron stents compared to Zion's and Resolute Onyx stents respectively. So also, if you look at the peak design of a Megatron stent, you find that it's actually a focused strut bending here. So the strain of the expansion is really on the strut rather than on the bend itself, unlike the Zion stents or the Resolute Onyx, where the peaks bend here. So this is the part that is marked green is where the maximum strain is. So when you deflect the strain off the peak, you find that the stent is less likely to go into a recoil state. And so Megatron stent has been shown to be of a less recoil of 2% versus 4 and 5% for the other comparator stents. So this again result in a larger luminal gain with less of acute luminal loss. what's also important here is that in the new MEGATRON design, you find that the balloon cone is now much less compared to a conventional synergy stand. So you find that in this case, when you want to deploy the stand in the large vessel, you're less likely to have this balloon to go overhang to cause injury to the distal vessel. So this gives rise to the unique characteristics of MEGATRON stand, where for the first time now, you could have a 3.5 stand that can be expanded all the way to a 6mm stand. And this is really important when you're dealing with a large vessel. Compared to synergy, the max is 5.75 millimeter in terms of diameter. So what is also important here is that when you stretch out the stand into the side branch, you can expand it up to a 5mm in diameter, and in the proximal end where there are more connectors, you can stretch it up to a 3.8mm in your maximum expanded self diameter. So good for, again, for a large vessel and particularly involving the side branch. So if you want to deliver a MEGATRON stand, you can use it in your conventional 5 French or 6 French. So if you want to deploy a 4.5 to 5, you need a 6 French guiding catheter. But if you want to use a guide sealer, then you need a 7 French guide sealer extension catheter if you want to deploy a 4.5 to a 5 MEGATRON stand. So if you call a Synergy XD stand as a stand designed to heal with extra deliverability, then you will call a Synergy MEGATRON stand to be a stand designed to heal with strength. So this is best illustrated in a case that I will share with you. This is a very complex patient, 73-year-old with diabetes and hypertension and chronic renal impairment, has got a previous aortic dissections from a traffic accident. He's got a previous coronary artery disease that was for which the diagonal was stented, and that there was a history of failed angioplasty through distal LAD stenosis. And then he came in with NSTEMI with recurrent pulmonary edema. The echo shows a preserved left ventricular function, and hemoglobin was, HbA1c was 8.8%. If you look at the right coronary artery, it's just got about a moderate disease in the mid segment. But if you look at the left coronary artery here, and particularly the LAD, you find that there's a severe narrowed proximal calcified stenosis and another lesions right at the distal end. But if you look at the other view, this patient has got both osteo circumflex as well as osteo LAD stenosis in the left main that is really very big. So this is another view looking at the ostium LAD as well as the osteo circumflex stenosis. And when you couldn't pass the IVUS down the LAD, but we can do it in the circumflex, and you find that this is the proximal circumflex stenosis coming into the nearly the ostium of the circumflex. And then when the left LAD comes in, this is the left main. So when we measure the left main, the reference diameter is 6.26 millimeter in terms of diameter. So this is a huge stand. So this is a patient with very complex calcified lesions, distal bifurcation stenosis, and that is got a significant mismatch in terms of caliber between the LAD and the left main. So the strategy was for me was a one of a modified T stenting, because I didn't really want to complicate the procedure very much. It's already a complicated lesions to begin with. So what I did was I did the PCI of the left circumflex artery, which fortunately is not very calcified to begin with on IVUS. So I could put in the stent in the left circumflex artery right to the ostium of the circumflex artery. Then I did a free wiring of a rotor floppy guide wire to the LAD artery. I could only pass the wire to about the mid segment, and I did a 1.25 and a 1.5 burr of the proximal LAD stenosis. That frees up the wire to go further down, and so that allows me to take a 1.25 burr to go all the way down to the distal end to also prepare the lesions. This is followed by post-balloon inflations, post-rotor ablation inflations with a non-compliant balloon of 2.25 and 2.5, followed by sequential stenting with Synergy XD stent, putting 3 of them. But the last one is a MEGATRON 3.5 by 20 millimeter stents that cover the left main as well as the osteo LAD. So this is followed by a port using a NC emerge balloon of 6.0 times 8 millimeter, which is available in my lab for the left main artery. and followed by a sequential 2 steps of kissing balloon inflation. First the circ, then the LAD, and then the kissing, followed by a report again here with a 60 millimeter balloon. So this is the final results here. I could achieve a good stent apposition even if the left main area of about 17.97 square millimeter, but LAD was a good size of about 7.9 square millimeter. So this is the final angiogram results. As you can see, fairly good results as far as the LAD and the circumflex stent and also the left main stent. So this patient is well after 1 year of follow-up. So in conclusion, the MEGATRON stent gives us a modification in terms of its stent geometry and design, which helps to meet some of the clinical needs for improved radial and axial strength, and also allows for a greater expansile characteristics up to 6 millimeter in diameter. It is a dedicated stent designed and purpose made for large vessel. It is, in my opinion, best suited for left main, osteo, proximal lesion, and particularly those that are heavily calcified where you need great radial strength for support. So with that, thank you very much for your attention.
So thank you, Dr. Tan, and your very nice lecture to introduce the Synergy Megatron. I would like to ask you and introduce next speaker.
It's my pleasure to introduce Dr. Kang Ji Hoon from the Seoul National University Hospital to talk to us about the strategies of IVUS-guided left main PCI with the Excel sub-study. Dr. Kang, please.
Yes, thank you for your kind introduction. My name is Ji-Hoon Kang, and I'm from Seoul National University. As was introduced, I will talk about IVUS-guided left main PCI with the advantages of the Synergy MEGATRON stent. Now, regarding the issues of left main PCI, we all know that the left main is the largest coronary artery that we have as humans, which is associated with a large extent of the myocardium. And we have many RCTs, for example, the Excel and the Noble RCTs, and also meta-analysis, one that was recently published in Lancet. However, we still do not have a very consistent way that we can treat these lesions with CABG or with PCI. We all know that the Excel and Noble trial were very controversial in the results, and the recent study, IPD Meta in the Lancet, also showed very confusing conclusions about the strategy for left main PCI. So we still have a very optimal question of how can we perform the left main stent implantation in a very optimal way. So again, regarding the IVUS, previous studies have shown that intravascular ultrasound guided PCI can improve clinical outcomes, and to be more specific, can improve the hard clinical outcomes compared to angiographic guided PCI. This was performed in many RCTs, such as the IVUS XPL RCT, and also retrospective studies from the BCIS and Korean retrospective studies also showing that the IVUS guided arms were superior compared to the angiographic PCI arms. So regarding IVUS evaluation, we have critical points that we can earn from these images. We can see the necessity of adjunctive lesion preparation. We can decide the device by achieving the largest lumen. Also, we can select the optimal stent length to avoid any kind of geographic mismatch. Also, we can inhibit any kind of stent under expansion after the PCI, and also inhibit any kind of stent edge dissection. And also, we can also find any kind of acute complications such as stent dissection and stent deformity. I would like to talk about the stent deformation issue in left main PCI. This is a very famous study that was performed in 2014. It showed that the left main was the most vulnerable site for any kind of stent deformation. And also the stent deformation was classified into 5 subgroups, which include a complete, partial the deformation or a malalignment or a fracture, and also deformation which is squeezing of the stent in the proximal part. This is the most common part that can happen in the left main PCI because of the anatomical features. Also, this was a study that evaluated the predictors of LSD. And also in this study, it was also showed that ostial lesions and left main lesions had a higher prevalence of any kind of longitudinal stent deformation. And also many other procedures were also associated with the LSD. Of course, we can see that in those who used IVUS, there was a higher prevalence of LSD, but I assume that this was not a causal result association, but it was just a simultaneous association saying that those who had risk factors for LSD had more IVUS evaluations. Also, regarding the clinical impact of LSD, this was a sub-study of the Excel trial, which was comparison of CABG versus PCI with the EES. And among the PCI arm, there was patients who received IVUS-guided left main PCI, which we know that is better compared to the angiographic-guided PCI. However, we could compare these kinds of two arms and see how the outcomes were. And also within the IVUS-guided arm, we can compare those who had any kind of acute stent deformation. So in the IVUS-guided left main PCI arm, we could see that there was a 6.5% of any kind of acute stent deformation. And during the 3-year follow-up, we could see that the stent deformation was associated with a hazard ratio of 2.3 for major adverse cardiac events. Regarding that, the stent deformation is a very subtle issue that we may lose in just angiographic findings. This is a very significant finding that we should focus on, especially in left main PCI. So in this study, study also evaluated the predictors of left main related MACE. Of course, we can see that the stent deformation has a twofold risk of left main related MACE. Also, other factors are all associated with left main related MACE, but interestingly, within those who had MACE, there was no difference in the minimal stent area, the stent area at deformation, the lumen area, and the stent ostium fracture, or also even the floating stent in the aorta. This means that the presence of stent deformation itself is a very not good, bad factor that can bring bad clinical events to the patient. If this patient has any kind of stent deformation, the other factors that we know that have clinical impact to the patient may not be important. So stent deformation is a major factor that is very bad that should be corrected in any kind of way. So regarding PCI for left main, for the left main, there are key features for a drug-eluting stent that should be that are good for a ideal left main stent. First is the high radial axial strength, which makes the stent very concrete in the very large left main coronary artery. Also, because the left main is a very short artery which can be tapered, the stent should have a large overexpansion range. Also, because of the large plaque volume, it should be optimized. Optimized scaffolding is very important, even in larger diameters. And also because the getting the ostium in the left main PCI is very important. The visibility is very important in the left main PCI. So these are the factors that have been combined into the Synergy, making the Synergy MEGATRON stent. So as Dr. Tan had just said, the Synergy MEGATRON stent has a very strong axial and radial strength. It has a very large overexpansion range that has been improved compared to the previous stent and also previous Synergy stents also. It has uniform scaffolding because it has very more peak to valley structures in the stent compared to the previous Synergy. And also we can see that the visibility is very good compared to other stents. I will show the visibility again in the following case. So this is the stent structure. We can see that there are 12 peak designs compared to 10 peak designs in the previous Synergy, making the Synergy MEGATRON stent having a more stronger radial and axial strength. And also we can see that there are more connectors throughout the body, which is also a factor that protects the Synergy's MEGATRON stent from any kind of stent deformity. Also, the stent structure is slightly thicker, but this is also one option that is making the Synergy MEGATRON stent a better stent for larger vessels. Also, as Dr. Tanat said, the focus of stent bending is deflected to the bar of the stent, which makes the acute lumen loss more smaller, which is also a very important important feature when we treat larger vessels such as the left main coronary artery. Also, the visibility is also a very important issue because matching the ostium is very important in osteal lesions. If we have a mismatch, there is a higher chance of any kind of stent deformation, and this may lead to a bad MACE in the future for the patient. So regarding left main PCI, another important issue is the DAPT issue. How long should we prescribe DAPT to the patient in these left main PCI patients, or is it okay to reduce the DAPT duration in those who receive left main PCI? So regarding that, the Synergy stent is very similar to the Synergy MEGATRON stent. Going back to the data from the Synergy, we can see that a lot of clinical data have shown that the Synergy stent is safe with a shorter DAPT duration, even in those with high bleeding risk patients. Regarding the Evolve Short DAPT trial, this was a trial that was published last year. It compared the patients who received 3 months DAPT to the historical comparator who received the Synergy stent, and showed that the stent death MI rate was very similar. The ST rate was very low, showing that the 3-month DAPT was a safe strategy in those with high BR. Also in the senior trial, which was again a trial that compared the Synergy with a bare metal stent in those with old age, which is a very important issue in the frailty, showed that the Synergy stent was safe compared to the BMS with a lower risk of any kind of MACE. And also we could see that in the individual factors of the MACE, the event rate was lower compared to the BMS arm, showing that the Synergy stent may be a optimal strategy that we can use for those who need a BMS-like DAPT regimen. Also in the POEM trial, this was a 1-month DAPT trial that evaluated those with high bleeding risk with the ES. Also, this showed that the event rate was very low. And also compared to other trials, we could see that the Synergy, the POEM trial, had a very low event rate in regards of stent thrombosis and bleeding events compared to other trials. So not only the trials that I have just introduced, a lot of trials were based on the Synergy stent, showing that they have a very concrete evidence of the safety and the efficacy on the PCI patients that we treat in the clinic. So I would like to show a clinical case that I used the Synergy MEGATRON, and I would like to highlight the advantages that I had using this stent. First, this was a 46-year-old male, quite young, and also had crescendo type of chest discomfort since 1 month ago. He was previously healthy, but recovered after COVID-19, and after this event, he had the chest discomfort. This patient was a low clinical risk patient, but again, it is important in treating the low clinical risk patients very thoroughly, because these patients have a longer follow-up duration compared to the old critical patients that we meet in the clinic. In the angiography, we could see that this patient had a long disease within the left main to LAD, while the circumflex artery and the RCA artery was quite normal. And also within the LAD, we could see that the ramus, the quite large diagonal 1, the diagonal 2 osteums were also compromised due to the large plaque in the left main to LAD. So we performed wiring to the LAD to the D2 to the RI, and in IBIS evaluation, we could see that in the left main, the lumen area was quite very large, which was up to 5 millimeters, and we could see that there was a large plaque in the LAD, which led to the mid LAD, which with a lesion length up to 40 millimeters. So I wondered if I could just treat this patient with 1 stent or 2 stents, but I prefer 2 stents because there was a very size mismatch between the mid LAD and the left main. Regarding treatment, first I performed a DEB to the RI because I didn't want to lose the RI, and I did not want to touch the left circumflex artery. So after that, I performed a PCI to the mid LAD with a MEGATRON, and this is a very low radiation fluoro, but we can see that the visibility of the stent is very good. And after that, I performed kissing balloon to the diagonal ostium. And again, I had very minimal difficulty in performing the kissing balloon. So one of the advantage of the Synergy MEGATRON stent is that it has a large flexibility in the side branching. So I could feel that aspect once in this process. And after that, I performed PCI for the left main to LAD. And again, I can see the previous stent. I can see the new stent that is coming out of the left ostium with a very good visibility, even though this is a very low radioscopic fluoroscopy that we did. So after PCI, I performed pod to the left main, and the pre-pod from post-pod, I can see that the lumen area we could have a larger lumen area, and also the minimal lumen area was minimal stent area was very large. So we stopped the procedure right here. So this is the final angiography. And so in this procedure, we had 2 stents with Synergy MEGATRON with a final kissing balloon into the LADT2, simple crossover to the diagonal 1, but we could see that the flow was still patent, and also pot to the left main. So I think that we stuck with all the good aspects in this patients and had various procedures that we could experience in this single patient. Also, after the angiography, we could see that the visibility of the stent was very good. So we could see that the stent had no stent deformity, not only in angiography, but also IVUS evaluation. So this is my conclusion. We still have many efforts that focus on PCI for left main disease, such as intravascular imaging, which merits in left main PCI, and also especially due to the anatomical features of the left main, the stent deformity is a very important issue that can be evaluated by IVUS in left main PCI. Anatomic features in the left main PCI require DS with a high radial axial strength, a larger overexpansion range, a optimal scaffolding, and a good visibility. So I think that the stent MEGATRON has these kinds of features, which may be a good option for the left main PCI. Thank you for your attention.
Thank you very much, Dr. Kang, for that very informative lecture. I'm sure we all have learned a lot from his case sharing, and I'm sure we also have questions, but we're going to leave it to the end of the lectures before we engage all of you in your comment. So I'd like to introduce the third speaker for this symposium. This is Dr. Nicholas van Mecham from Erasmus Medical Center in Netherlands. And he's going to share with us a case of large vessel PCI involving the right and left coronary artery. Nicholas, please.
Dear friends and colleagues, in the next 10 minutes, I will discuss through some cases why I think the Synergy MEGATRON stent is an important tool in our treatment armamentarium as we're doing PCI in complex coronary cases. These are my conflicts. And we already discussed in this session the key features of the Synergy MEGATRON stent, but just to summarize, it's the best in class in terms of axial and radial strength, and this is exactly what you want to have when you're treating osteolesions, large vessels like left mains, and also in ectatic arteries. So you can also have a clear overexpansion of your stent. This is the 5 millimeter MEGATRON. You can extend it all the way to 6 millimeters. It is also a unique form of scaffolding. You see, as is illustrated in this little picture here, and on the right below, you see that it's more visible than your typical stent. And also, again, if you are aiming for an osteolesion, you want to have a visible device. There are some other features that explain these personality aspects of the stent. It's the platinum chromium alloy. There is the optimized strut thickness and width. And you have this different set of connectors proximally and more distally that enhance the axial strength of the device. So let's go to the first case. This is a 61-year-old female who was brought to the hospital with a non-STEMI. And if you look well at the right coronary artery, you don't see any backflow at the ostium. Very difficult to appreciate whether there is a lesion or not, but you don't see the backflow. And this is where IVUS comes in, because we need to explain what is going on in this patient. Why is this patient experiencing chest pain? Why are the troponin levels elevated? So our region of interest is the proximal segment of that vessel. And here we are approaching the ostium, and boom, the ostium really has a napkin lesion that could explain the patient's complaint. Given the size of the vessel, and here we are representing basically the size from distal to proximal, and as you can understand, this should be more or less similar, or if anything, larger proximally as compared to distally. It's not happening, so you see a tight stenosis at the ostium if you look at the average diameter in blue, the minimum diameter in orange, and the maximum diameter by IVUS in gray. So very clearly visible that there is a severe stenosis at the ostium of the RCA. So we approached this with a cutting balloon. This is a Wolverine 3.5 millimeter balloon at the ostium, followed by a 4.5 Synergy Megatron stent. This is the result after stenting. We post-dilated based on the IVUS with a 5 millimeter non-compliant balloon, then redid the IVUS, and now you see that there is no longer a tapering at the ostium of that RCA. Basically, we came from 2 millimeters and extended it all the way up to approximately 5.5 millimeters. Mission accomplished in this patient. Here are her final angiograms. She has done very well afterwards. The next patient is a 66-year-old female, also presenting with a non-STEMI, and guess what? Again, there is this ostial lesion in the left main. No backflow, and if you focus on the spider view, you can tell that there is an indentation right at the ostium. This patient was hemodynamically unstable, so we used a mechanical circulatory support with Impella to facilitate this procedure, because we want to have all our tools available in this patient. We anticipate heavy calcium, we anticipate left main disease in a patient with depressed LV function. Better be prepared for some support. Again, IVUS is an important tool to determine our strategy, to select the kind of lesion modification that we want to do. And as the IVUS is running, you can see again that going to the proximal part, so distally we are in the LAD, then we enter the left main, but as we approach the ostium, there is a severe tapering of that left main to a diameter of less than 3 millimeters, clearly visible here on the IVUS as we are entering the aorta. So we proceeded with a pre-dilatation with a 408 non-compliant balloon, followed by a 4.5 by 8 Megatron, Synergy Megatron stent. And this is our angiographic result. Patient remained stable throughout the procedure. Very pleased with the support we got from the Impella. And then we topped off the case with another IVUS run. And basically what you see is, starting in the LAD, as expected, the lumen increases in the left main, but there's no longer this tapering down at the ostium, really a solid vessel. And I think a very nice result also shown by the IVUS images here. There is some eccentricity, but this has to do with the amount of calcium that was present in that left main. So I think a very good result. And again, this patient was discharged in good health at the end of the procedure. This is her final angiogram, a spider view. There is no more indentation. This is the caudal view, and you can at least appreciate again backflow with the guiding catheter engaged in that left main ostium. The last patient I want to show you is a 63-year-old male who was brought to our hospital after out-of-hospital cardiac arrest. This was this angiogram. Proximal LAD, there is a severe stenosis, but look at the LAD further down. It's ectatic. It's an ectatic vessel. So again, we want to understand and determine our strategy. We bring in back the IVUS catheter, large vessel. There is disease, non-obstructive disease, distally in the LAD. And as we are approaching the lesion, the disease is accumulating. Here you see the overview as we are entering the severe tight stenosis and the culprit of this patient. And you see that there is a clear dip at the ostium of the LAD right before entering the left main stem. But also you can appreciate the enormous size of this vessel. It's more than 6 millimeters in the left main. It's up to 5 millimeters in that proximal LAD with that tight stenosis. We implanted a 5.0 by 16 MEGATRON stent, and that looked angiographically already very nice. We continued with, again, an IVUS to look what our result is. Do we have proper apposition expansion of our stent? How does it look in terms of obstruction? And again, throughout the vessel, it now becomes a very large structure of around 6 millimeters, starting in the proximal LAD and all the way into the left main. So basically, we solve this problem with a very good stent with nice expansion, radial strength, axial strength. We are very pleased with this technology, and also is this patient, because here you look at final angiograms. We started stenting in the left main, but you see the extension into that ectatic segment of the LAD with a proper, apparently laminar flow. What I have demonstrated in these three cases is that good PCI techniques go hand in hand with invasive imaging and proper stent technology. There are several randomized controlled trials evaluating this principle of IVUS-guided PCI in complex lesions, and this is the one that I'm leading together with my colleague Roberto Diletti. It's an international trial on CHIP patients where over 2,000 patients will be randomized one-to-one to either IVUS-guided versus angio-guided PCI. And I know in Asia, IVUS has been adopted much more than in Europe. So I think, and I hope that this trial will establish the value of IVUS, at least in these complex cases. And the optimal randomized controlled trial focuses entirely on left main PCI, 800 patients, one-to-one randomized to either IVUS-guided PCI or angio-guided PCI in the UK, Spain, and Italy. So to conclude, I think the Synergy MEGATRON stent has interesting features for complex lesions, osteal lesions, ectatic lesions, left main disease. It has a good stent platform, but you always want to combine it with IVUS guidance, especially in these complex morphologies. And I think the combination of a good stent platform and IVUS is the foundation of a successful PCI. And there are randomized controlled trials ongoing to prove that concept. I thank you for your attention, and I give the word back for more discussion.
Okay, great lecture. Thank you all lecturer, and all the lecture is very informative. Learn the typical feature of the Synergy MEGATRON, the stand. So we will have a 15 and 20 minute enough discussion time. So for lecturer and Dr. Tan and Dr. Gang and any panelist comment or question to the lecturer. Okay, Dr. Lim. Okay, Young-Hyo Lim.
Hi.
Okay, go ahead.
Yeah. Hi, nice to meet you. I'm Young-Hyo Lim from Hanyang University, Seoul Hospital. I have a short question to Dr. Gang. Thank you for your nice lecture, Dr. Gang. I think that about 5 or 6 years ago, long LSD was a problem with proximal region PCI with pronounced element, but now the issue has diminished a bit. So it seems that LSD is more likely to be caused by the operator's negligence or mistake than the stent problem. What do you think? And also, as with the Synergy stent, it felt like it happened more because base stent, the platinum chrome based stent are better observed than other stent. What do you think?
Yes, thank you for the very, very good comment. I agree that because in about 5 or 6 years ago, we did not have many experience of the stent deformation. We did not know that. We could see that with stents with better visibility, but I don't think that this means that those stents with lesser visibility did not have any kind of stent deformation. However, theoretically, the stent deformation is a very important issue in osteal lesions, it's left main lesions. It's very easy to happen. When we do the procedure, we oftenly see that the guiding catheter gets sucked into the left main, which can somehow give any kind of deformity to the stent. Also, of course, even after that kind of guiding catheter going into the left main, we just wish that there's no deformity in the stent. We cannot confirm the issue. So having one of these kinds of features in the stent which can somehow decrease this deformity in the left main, I think that's a very good issue. And increasing the visibility gives us a more good chance to find that kind of problem that we might neglect in other stents. So I think that this is a very good this is a very good feature of the Synergy stent.
Okay. So Dr. Zhang.
Okay, this is Jessica Zhang from Korea, and I have some question to Dr. Tan. I think Synergy and MEGATRON is a very talented stent to cover left main, large proximal vessel with low probability of stent formation. So my question is, what about the deliverability? So sometimes we meet severely enlarged ectatic vessels, even in distal vessel lesion. So does the MEGATRON stent has same deliverability with other stent like Synergy XD, or even in very tortuous distal but still large vessel lesions? And what do you expect, or do you have any experience?
Or if I have to say that there is one limitation of MEGATRON stent, and that will be the deliverability, chiefly because it's much thicker in terms of strut thickness, and also it's because of the number of connectors. There are more connectors now, so you make it stiffer for it to be delivered to a distal vessel. But remember, MEGATRON is really designed for a proximal big vessel stenosis. It's not meant for distal vessels and so forth. So rarely do we have huge vessel in the mid or distal segment of artery. But should that happen, then perhaps some kind of extension catheter support may be necessary. Say, for example, you want to use Geisiler and so forth to deliver. But really, this stent is custom-made and dedicated for big vessel stenting. And I agree with you, it is a limitation as far as deliverability is concerned. What is also concerned to me actually is also because of the increased strut thickness. Dr. Kang has mentioned just now about ideal left main trial, where actually in the OCT study shows that almost the entire stent struts is covered in 3 months, in patients who receive normal Synergy stent. Whether MEGATRON stent will have the same level of healing as a conventional stent, Synergy stent. We know that is the strut thickness is about 89 for a MEGATRON stent. For Synergy, workhorse is about 79. Whether that difference of 10 micrometer makes a lot of difference, whether we can still confidently give 1 month of PT if the need arises, or do we have to go longer? So I'll be curious to hear from my fellow colleagues on the healing property of a MEGATRON stent.
Great. So I'd like the comment for the Dr. Yi-Sik Kim. And in your practice before the starting MEGATRON has some much improved radial force for, I guess my just technical guessing is it would be some suitable for, severe calcified region. And even though we put the left main stenting, if there is some severe calcified region, IBUS final checking shows some eccentric, deformity. So, and Dr. Kim, and in your practice, and when you treat the severe calcified region, and which drug-eluting stent usually you prefer, and the Giants or Ledger-Loot? Is it how do you stop?
Oh, it's very sensitive question. Yeah, actually, I try to choose it a little bit. Yeah, yeah. I choose more thick and the stand with more axial strength. Yeah. So sometimes I Routine master, yeah, something like that. And so,
Okay.
but I can I question? Yeah.
Okay, you go ahead.
Yeah. Yeah, 3 lectures introduce kindly Megatron's nice design and some good points. Yeah, Megatron standing seems to have nice design and especially good axial strength. Yes, but it's good for calcified lesion and for lumen loss. But my concern is Dr. Kang mentioned the rectal meninges, but during the rectal main procedure, sometimes we need to two-stand technique, crush technique, something like that. So, but my concern is there can be a little bit disadvantage for crush technique and two-stand technique because it seems to too strong.
Radial first.
Yeah,
Is there any comment, panel or Dr. Tan? Do you have experience for? I guess this is some expected question. Megatron has a slightly thicker, or radial force is much strong, or bending portion is much wider. We concern after left main stenting is crush and the suck ostium is a recross and the final kissing. Do you have any experience, Dr. Tan or Dr. Gang, and any panel?
So maybe my comment here is that Megatron stent is meant for huge vessels. So when you have a large vessel, then the extra thickness may not matter so much. But if the left main is relatively small, between 4.5 to 5, actually a conventional Synergy XD stent can also do the job because it can be expanded all the way up to a 5.7 if necessary, or no, 4.7, 5.2. Actually, you can go up to 5.2 even for a normal Synergy XD stent. So it's meant for large vessel. And so if you decide to use Megatron, then you should really size it to use it in an appropriate sort of setting. But also because the crossability is so good, because of the potential large cell diameter, actually it helps in terms of a two-stent strategy as well. So I don't think it is a downside today, but I do appreciate that there may be some technical challenges in terms of delivering the stent.
Great.
Well,
Okay,
I have
Dr.
one
Ki?
question.
Okay.
Yeah.
Okay,
yeah.
Yu Jung-ki. Okay,
And thank you for your good presentation. I have a question to Dr. Jiung-gang. IVUS affect the choice of atherectomy or balloon size or stent size in my practice. The benefit of using IVUS are huge, but in Excel IVUS sub-study, I wonder why 25% didn't use the IVUS in Excel study. What was the main reason for not using IVUS?
Yes, thank you for the question. Actually, the Excel study was originally a study that compared CABG versus PCI in left main disease. So the left main IVUS usage was just up to the discretion to the primary physician. So as we are all Asian physicians, even in a Western study that had a IVUS usage about up to 60% means that the rate is very, very high, even in those kinds of lesions, in those kinds of regions. So it was just because, I think that it was just because the primary physicians was not familiar compared to the IVUS, or he was confident, he or she was confident that they could perform the procedure just as perfect even without IVUS, which is actually sometimes as we feel in the clinic also.
Yeah. So I would like to ask all the panel and discussant, and it's another part in this symposium is the use of the intravascular ultrasound in Korea, Japan. The overall use of intravascular ultrasound is very high. I think in the highest in the world. So recent trial, phase 3 trial, just 11% use IBUS for PCI group is very low. I think there is some daily practice in United States. So, last 5 years, there are many publications, random trial, IBUS, XPL, Myung-Gi Hong is PI, published in the JAMA, showing the better outcome with the long region. Also, IBUS CTO study, also ultimate study in China in complex and all-comer setting, IBUS was better. But it's as shown in the Dr. Nico the presentation, still similar concept. Clinical trial RCT is ongoing. IBUS chip trial, OPAL trial for targeting left main is the design is the same. IBUS versus angiography. How many RCT should be done? How do you think? You really require all concept, the same concept RCT for left main bifurcation. Is we done the long region, we done some CTO region, is some ongoing left main. How do you think? We require consecutive RCT for every region? How do you think? And
I was seen. In conclusion, I was seen.
Yeah, I was seeing. It's Dr. Tan and Dr. Zhang and is Dr. Ki. And how do you think? We require more RCT?
Personally, I don't think that we need any more RCT or any other studies for every region subset, because many data has accumulated so far, and I don't think we need more RCT data at this time point.
Yeah.
Well, the RCTs have certainly shown that the use of intravascular ultrasound have improved the major adverse cardiac event following PCI. But what we really need here also is a mortality advantage. And although there is some observational cohort study and so forth suggesting that IBUS may lower the mortality rate, but I think in the RCT setting like optimal and so forth, this will really give us the additional data to support the use of IBUS. I think the use of IBUS really depends pretty much on the individual country's healthcare system reimbursement and also the practice and culture within the healthcare system. So I think education is certainly one of the key, and also not just in terms of pulling out the IBUS catheter, but able to use the criteria, the targets as to how much of a optimal IBUS is considered good enough in terms of post-PCI results. It's something that we will have to continue educate, and then I think this forum is just perfect.
Okay, great.
One more thing I have an opinion about IBUS is that we all know that IBUS approach is better than angiography, because this is doing more, having one more medical resource to the patient. But above that kind of fact, above the fact that IBUS is better than angiography, what we don't know is what features of the IBUS are really related to the future MACE. Is it the MSA? Is it the minimal stent area? Is that all? Or is it the lipid-rich plaques? Or is it the stent deformity issue? So IBUS being better than angiography, this is a very simple conclusion, but beyond that kind of conclusion, we have many issues that we can earn from the IBUS evaluations, which gives us a lot of clues to how to treat the patient. So I think the RCTs have that kind of meanings in our patient.
So my one question is, Dr. Gang, what is the in Excel sub-study definition of a stent, deformation? How they define that?
Actually, in the Excel sub-study, the deformation was, as I shown you, the 5 criteria of the crushed stent, the fracture, any kind of findings that was evaluated by the core lab. So the deformity definition was slightly a subjective definition, but still, because it was confirmed on IBUS, it was there. It was not a subjective finding.
Yeah, I would like to ask Dr. Zhang and Dr. Rim, and after final kissing dilation for distal left main, is many physicians suggest the additional part to make a concentric configuration of the left main ostium, but this even in the proximal LAD bifurcation region. But my impression, even though some eccentric part, the proximal part, it doesn't matter in clinically. But in some physician is try to the more circular the configuration after checking up the eyebrows. How do you think in your daily practice? Is there you do frequently do the part or some effort to make some more concentric configuration? Dr. Zhang and Dr. Lim, how do you think?
Yeah, many doctors and practicing doctors believe the part of the left main or occipital region is very important. So sometimes I forget to do part after PCI, but my colleagues or technicians every day call me to do part to ensure the maximum dilation of the occipital part of the vessel. Yeah, so usually in my practice, I do part every day. Yeah,
good.
Always.
Good. It's a good looking food. It's
good
much
looking.
delicious.
I think so.
Okay, Dr. Lim. Okay, yeah, Lim and Tam. Okay, Dr. Lim. Okay, you're muted.
Yeah, but in my usually practice, my daily procedure, I do not do proximal part because the another use the another balloon is needed. So, but especially the left main bifurcation, as I do the final kissing. Final kissing is very important to more to better outcome.
Great. Okay, Dr. Tan.
Well, one of the comment here is that, the ellipticity index has never been a predictor of outcomes. So whether the eye will show a more concentric or more elliptical actually really doesn't matter. The second point here is that in a left main vessel, which is very large, actually, if you can achieve something like 5.5 or something like that in terms of diameter, even with the little amount of malapposition, actually, it is not a problem because the left main is just so huge and the flow is good. So sometimes in the situations where you don't have a large non-compliant balloon to do a post-stent dilatation, actually leaving a little bit of malappositions may not be an issue in a large left main artery.
Great. Any question or comment from panel?
I have one more simple comment and question. Sometimes left main occipital accommodation is very difficult. So I know that the proximal end of the stent strut in synergy stent is located in 1 millimeter or so behind the marker. But in giant stent, the proximal end is just in the middle of the marker. So do you have any tips to accommodate the exact location of the oscium of the left main? Okay.
So, okay, any comment, Dr. Tan, and you have experience? Yeah, usually, yeah, okay, go ahead.
So I agree with you that the stent strut does not begin at the medial border of the marker. And that is something that you need to know about the product as well. And so you have to take that into consideration as you place the stent. But the good thing is that because it's generally quite radio opaque, I can see the stent quite clearly as I decide where to position it. But it is a challenge, yeah.
Okay, any comment or question? So, okay, the nearly time is complete. I think that this satellite symposium session is a very nice, best time to introduce a new technical feature of synergy MEGATRON, also clinical usefulness of intravascular ultrasound. That is absolutely landmark product in Boston Scientific. So I think that this educational symposium is very helpful to all of the audience. I hope in the next year, after using MEGATRON for wide, complex region, including left main and bifurcation region, absolutely, I hope the next year we have some cumulative our clinical experience with the synergy MEGATRON for complex region. Absolutely, I hope every person we meet in person meeting the next year TCTAP 2023 the meeting. I hope everyone is be careful and healthy always. I would like to close this session. Thank you for all your participants and your contribution. Thank you.
Thank you very much.
Thank you very much.